So we are now, I hope everyone had a good lunch and is well rested. We are now going to have our headache session. And so you may be wondering and asking yourselves why there are two vascular neurosurgeons and a pharmacist talk. Well, the pharmacist part makes sense actually, about a headache talk. And like everything that we do, we kind of think about things a little bit differently. So our thought process with setting up the headache talk was rather than going through a exhaustive description of the 150, and there are, I think, about 150 variants of different types of headaches, and going through each treatment and all of that, we want to talk about how we at GNI are tackling headache. So again, just some background, and then we're going to kind of get into some discussions of some innovative things that we're doing here at GNI. We all see headaches. I mean, everybody in healthcare at some point in time, whether you're an OBGYN, an ER doctor, it doesn't matter, you're going to see and deal with patients with headaches. And quite frankly, probably 60% of the people here and out there have headaches. I know Ken and I both have migraines that we've suffered through for a very long time. And I don't know if you do or not, but you know, and there's not a lot of great help. There's not a lot of great data. And I'll let everybody know a secret as a starting point, and hopefully this will stir up some conversation and controversy. No one knows what the hell is the etiology of most headaches. When you start hearing about 150 different types of diagnosable headaches, that means we don't know what the hell we're talking about, and we're just kind of describing what we see. So I guarantee you we could bring three headache experts up here, and they would all have a different idea about the etiology, and we have some ideas. But the bottom line is, if you go to most headache centers, first of all, it's a 6-month wait to get in. The first line is usually an infusion. They start going to ketamine, some pretty powerful drugs for headaches, and there's very little in the way of diagnosis. So we as vascular neurosurgeons in our group see a lot of our patients have headaches, right? And so somebody's diagnosed with a 2-millimeter aneurysm, and it was diagnosed because they have headaches. That's right. And then everybody freaks out because, oh my God, I have an aneurysm, and are the headaches because of the aneurysm? And actually, we wrote a great paper with Mitra Sadi at Capital, remember, about the having an aneurysm with a headache, and then once you treat the aneurysm, do the headaches get better or not? Right. Especially from an endovascular approach, which was interesting. But the point is that the headaches have nothing to do with the aneurysms. Then the patient's like, okay, well, that's great news, but what about my headaches? And so what we decided was we got really tired of our patients coming back and either saying, I can't get into a headache center, or the treatments just don't work. And you know, we've seen it all. I mean, I know your head spins when somebody's placed on Percocet for headaches as a first line, or narcotics. You know, antiepileptics, some pretty powerful medications. Absolutely. So we started off, and we went, as we always do, to Natalie, and we said, Natalie, we want to at least try to help our patients with first line, and came up with, and actually Peter Glebus, our neurology colleagues, and again, this center that we're doing is with neurology. So this is, you know, you're going to hear more about this from our neurology colleagues as well. But you know, we start off, everybody went out with magnesium and vitamin B2 as a first line. And I actually made fun of Dr. Glebus, and you guys were like, come on, magnesium? That's not going to help headaches. That's like holistic stuff that's, you know, natural. And it works. I use it. It works really well. It's really safe. And I would say, I don't know, what do you guys think? Maybe 10% of the time?
Well, I mean, the thing that we have to remember is magnesium B2, and then we oftentimes actually even combine it with CoQ10 is another one. Right. Yep. Butterbur is another one. We go to these holistic treatments because if we don't start with a holistic treatment, then your other option is actually an antiepileptic. Right. So you pick your poison.
That's exactly right.
But we have to, when we start these agents, we have to tell patients that they have to be patient. Yeah. And that's the number one message, that when we talk to patients, we say, this isn't going to be an overnight cure. Right. You need to give time for these medications to work. Right. And I say medications because they do have medicinal components. Even though it's holistic, we know if somebody has almost any kind of pain. I know right now we're talking about headache pain. If we give them 2 grams of a MAG infusion, they're going to start feeling better.
Oh yeah. Absolutely.
And I think it's really a good point to emphasize that we start off with a holistic approach, not just with a narcotic, not with a tricyclic antidepressant, not with a anticonvulsant. I mean, and the doctors, the Western medicine doctors, are starting off with a more of a holistic approach. I think that's fantastic.
Yeah. And I want to really emphasize, I'm not making fun of it in any way, shape, or form. And I'm not even sure. I mean, holistic basically means taking care of the patient.
That's
and
right.
Looking at all the different variables. And magnesium makes more sense than magnesium's a neurotransmitter. It affects the vessels from a vasospasm standpoint.
Right.
We know that's the etiology of a lot of these migrainous medications. So I mean, there is science behind it. It's not just like we're saying go out and meditate or do something. And actually, meditation helps. But that's the point: is evaluating the patient. So the process is of bringing the patient in, evaluating them, listening to them, talking about stressors in their lives. I can't tell you how many times, and I know you guys are. Patients that aren't getting enough sleep.
That's what I was going to say.
They're like, I'm really stressed out. I'm not sleeping enough. Well, yeah, you're going to get headaches with that. So kind of going directly to that route. And then we said, you know what? We're going to set up a headache clinic so that first and foremost, we can get patients in immediately. We can get them right in, not wait 6 months, not wait 3 months. And Natalie's brilliance with this, of her really directing us with this setup is we see the patients together with Natalie. We start off in this stepwise approach, and we'll talk about the pharmacotherapy a little bit more. But I think the most thing that helps the patients most, you call them after 2 weeks or a week.
Yeah, so that's actually something that even our APPs have been able to participate in through our outpatient clinic, where we have found that a lot of times in an office setting, we start a patient on a medication, and then we say, okay, we'll make a follow-up appointment, and that follow-up appointment could be in a month, it could be in 6 weeks, it could be in 3 months. And what's happening to that patient in those 3 months? It could be a multitude of different things. They could not be feeling better, they could be feeling better, they could have side effects, they could have stopped the medication because of the side effects.
Right.
Maybe they increased their medication on their own for some reason. So what we've done through our APP program is we actually have follow-ups every 2 weeks with the patients, so that we're able to come in and say, it's been 2 weeks of this medication. How are you feeling? Have your headaches increased? Have they decreased? Do you feel any side effects? If your headaches have decreased but not to the full extent, should we go up on your dose? Should we go down on your dose? So that next time when they actually come see us in clinic, there's been progress into what we've done for them. Instead of just said, oh, well, it hasn't worked, here's another here's another change, and then we'll see you again in 3 months. So now, instead of wasting half a year on minimal changes while the patient is suffering, and I'm sure all of us have at one point in time had a headache. We're not even talking about migraines, but you've woken up one day and you've just had debilitating pain from a headache. And that, to somebody that suffers from chronic headaches, it's life altering. It's something, yes, it's something that, it affects your work, it affects your productivity, it affects your mood. So being able to quickly decrease or increase or stop or change medications between actual office visits is huge for patients. It's something that they feel that they're actually being listened to, and not just, okay, we'll take 2 and then call me if something is wrong.
Right.
We're proactively reaching out to them and saying, we care, we want you to feel better.
Right. And we know you as a patient. We know your history because you're talking to someone. I mean, it's remarkable, because going back to our previous lifestyle in the factory, where it was like, patients were so many. Here it's like, Mrs. Smith, yes, we know, okay, you tried this didn't work. And I think a really important point of what you just said is, I think we spend more time taking patients off of medications, because that's what doesn't happen with everything, not just headache. Somebody gets put on a medication, there's no adverse effect, but it's not helping, and nobody takes them off of it. So now before you know it, you're on 7 different medications, 4 of which are doing nothing, and now you're starting to get side effects from them. Nobody knows what's going on.
That's one of the more common questions we get, especially with the headaches bleeding into facial pain. And it's a very common scenario in terms of medicine. And I'll tell you, probably the most frequent question that I get is, well, should I keep taking the X, Y, and Z med. They're doing nothing for me. And I say, well, why are we taking that?
And
nobody.
you're a vascular neurosurgeon, so we as
That's right.
super specialists are doing what patients, whoever put them on these medications. It's crazy.
I know it's interesting. Yep.
So
Speaking of questions, a couple came in regarding magnesium, the
Great.
type of magnesium. Sulfate, gluconate was the question.
Sure. So over-the-counter magnesium tablets, the one that I recommend is magnesium oxide. It's the one that's least abrasive on the stomach. It usually comes in 400 or 500 milligram tablets, and we recommend to take 2 tablets once a day. If it does have any kind of effects on the stomach, you take 1 twice a day. You split up the dose. If we're doing an infusion, at that point we would go to magnesium sulfate, the 2 grams of magnesium sulfate.
Perfect lead in. The second question was with IV magnesium. How often can you give it, and what is the maximum dose in 24 hours?
So I tend to stay with just the 2 grams in 1 24-hour period, because with every type of medication, there are safety parameters that we have to stay in. And one of them is your magnesium level. So we do not want to make anybody hypermagnesiemic. 2 grams of magnesium isn't going to significantly raise your magnesium levels, but at the same time, we really don't want to go higher than that in a 24-hour period for a patient that does not need magnesium repletion, or for patients that are not getting excess amounts of magnesium if they're preeclamptic or in other situations. So we really just want to stick with the 2 grams for the most part.
In the dose of vitamin B2.
The vitamin B2 dose is also, we go a little bit higher than probably what's labeled. We do about 400 milligrams of the vitamin B2. And again, you can split that up, or you can do all 400 milligrams at once.
And they're very safe. I can't emphasize that enough, and we have the professional here, pharmacists, who can verify that. They're very safe. I take those doses all the time. And the thing that I love about it is it works, but it also, there's no sedation. I mean, I can go do brain surgery and take these, whereas any other medication, there's always some type of side effects, whether it makes you sleepy, whether it makes you nauseous, whatever. So it's very, very safe. And I think that's usually the patient's first question, is, especially when you're talking about higher doses.
Right, and to me, it's low-hanging fruit, because when you start the algorithm of preventative medications, they're all sedating, they all have interactions,
Absolutely.
They all need monitoring of some sort, whereas these are vitamins.
Right.
They're obviously, you don't want to take the entire bottle of magnesium all at once, but they are.
That's our disclaimer.
That's right. Words
do
of
not
wisdom.
take the entire bottle, but it is something that we feel is a good first step, and it's something for the patient to say, okay, I'm used to taking something every day now. It's not affecting me negatively. Let's see what else we can do. Does it help? Does it not help? And we ask our patients to monitor their headaches to make sure what are they feeling when they have a headache onset. Is it an increase in blood pressure? How many hypertensive patients have we found?
Yeah, of course.
They come in because they're complaining of headaches, and we
the blood
find
pressure,
out
right.
they're just hypertensive.
Exactly right, and it's incredible how many, and that's a really, first of all, it's an important solution, right? Because you're treating a patient's, untreated hypertension,
That's right.
plus you're taking care of the headaches. And then, I think going through lifestyle, the headache journal is really important, but I don't think it needs to be too overdone. I mean, most people know they have a pretty good sense of when their headaches
Right.
come, and
you
there are the different types of diets, sleep habits, stress in life, things like that. That being said, once that's taken care of, I mean, any healthcare provider can do what we're doing, because you're starting off with these first-line treatments of the obvious. Then it's when the escalation comes. And I think that's where it becomes more of an issue of not your variant headache. I mean, the patients that are coming to us now and have been on anti-epileptics, have been on every type of medication. They've done meditation, they've done holistic approaches, they've changed their sleep habits, and they're still getting these bad headaches. So that's where I think now, if you want to, I don't know, Natalie, you want to talk a little bit about our protocol of where we start with, after the magnesium doesn't work, and which steps we go to and why.
Absolutely. So the first thing that the first thing to say is we see a lot of complex headaches because we have a neurosurgical clinic. So a lot of our patients actually present with headaches post-neurosurgically, and it's almost what came first, the headache or the surgery. And a lot of times we find out that they really had an underlying headache issue and it had nothing to do with the neurosurgical issue. So we have to tease that out. The other part of it is we have to see what else is going on with the patient. A perfect example are hemiplegic migraines. So we had a patient that came in several times as stroke alert.
He was a priest.
Yes.
And he's giving sermons, and in the middle of the sermon, he would get an expressive aphasia. He had, was given IV TPA a couple times.
And so in that case, we actually had to halt and say, stop TPAing this guy.
That's not a treatment for headaches.
This is not the right treatment. And we did a workup and we found several treatment options for him, and he hasn't had hemiplegic migraines since. So we have to take a look at what the symptomatology is of the patient and what other disease states the patient has. So as an example, Dr. Azizi in our previous talk mentioned wanting prophylaxis for seizure management. So if somebody is a known epileptic, or if somebody needs seizure prophylaxis, we're going to start them on some valproic acid.
Right.
It just makes the most sense because we're not increasing the amount of medications they need.
Right.
They're getting an anti-epileptic and something for headache prevention. The same thing if they have any kind of mood disorders. So a lot of patients we know that whether it's because of a traumatic event that they had due to the surgical issue that they had, or just in general, like a personality issue, again, valproic acid would probably be the best agent for them as a mood stabilizer. If somebody presents and says they're having trouble sleeping, probably a better agent for them would be something like a tricyclic antidepressant. We have to take a look and really listen to what the patient is telling us their secondary symptoms are in order to treat their headaches. I think everybody says, okay, everybody's going to get topiramate, everybody's going to get the standard, 25 milligrams twice a day, and then we'll see you later. And that may not be the best thing for the patient. What if it's a high-functioning individual and they now can't talk because of the topiramate?
Yeah.
Right.
So
and it gets back to, I think, a theme that we've been talking about for the last couple of days. Medicine and healthcare is an art. I mean, it's listening to the patient, it's making decisions. Our saying that protocols make people stupid. You can't just say this, then this, then this. You've got to adapt to each individual patient, what the situation is. And what I've also realized is the role of beta blockers, like propranolol for headaches. And if you think about that, that's a lot of people take propranolol before they're going to give a speech, or when they're
That's exactly right, for essential tremor.
For essential tremor, before they're so they're going to do something anxiety provoking. So a lot of that role is patients that have stress-induced, I'm sure, headaches, that beta blocker is helping with that. But to your point, if they also have hypertension, or they're already on other antihypertensives, you got to be really careful if you're giving that, because then you're going to bottom their pressure out.
But your point's a really good point in terms of listening to the patient. As you mentioned, over 150 types of headaches. And again, you're certainly not going to go through the differential of all the different 150 types. But the point is, I saw a patient in the clinic who was diagnosed with cluster headaches, but actually they had trigeminal neuralgia in the V2 distribution. So I was talking to the patient and saying, it doesn't sound like cluster headaches, and we tried some different agents and it worked well. So listening to the patient, understanding that not every headache warrants right to an antidepressant, right to an anticonvulsant or narcotics, and take there is an art form to it, and I think that's a really important point.
And just going back to your trigeminal neuralgia, they almost marry headaches and trigeminal
right.
neuralgia at some point because of locality, and trigeminal neuralgia could be missed because you're going down the headache route, or vice versa.
That's right.
You could be going down the trigeminal neuralgia route, but they're still suffering from headaches. Your patient with the bilateral glycerolrhizotomies, she actually is a great case because she had both, and it was a 57-year-old female.
Yeah, she's a young woman, very atypical.
Yeah. She had bilateral glycerolrhizotomies, and she was actually receiving Botox for her headaches. And
It's exactly right. She was a very just. It's not that I jumped to glycerolrhizotomy right away. I mean,
Dr. Liebman, by the way, is the national expert, and certainly in the tri-state area.
I saw you look at me when you
facial
said that,
pain.
you're like,
I
what?
mean, all kidding aside, you've helped a lot of people from jumping off a bridge with that.
Yeah.
But she was refractory to all sorts of all the medicines, and it's a great example of a person who just kept adding to medicines without the medicines helping. She was like on a laundry list of medicines, and she said to me, "Do I need to take these? They're not helping me." I said, "Well, I'm going to have Dr. Gofman give you a call and try to adjust some things around." So.
Well, interestingly enough, I was speaking with her, and she's like, I get my Botox, but like I've noticed lately my forehead's moving. And I'm like, well, yeah. I mean, how have you noticed this? Is it just when it's time to get your next injection, or when is your forehead moving? She's like, no, the last 2 injections I've had, so it's been 6 months now. My forehead's moving
Right.
after the injections. And I'm like, well, I think you've developed antibodies to the Botox.
That's actually really interesting.
Yeah, and she's like, what does that mean? And I'm like, well, we have actually 2 different types of botulinum toxin, botulinum A and botulinum B. And I reached out to Dr. Jill Farmer, who's just an expert toxin injector in general. Mm-hmm. And I said, would you be able to test this patient do a frontalis test for toxin antibodies? And she did, and she's actually going to be receiving botulinum B toxin to paralyze her forehead, because that's where she was now complaining of her migraine headaches since the glycerolrhizotomies helped here.
Yeah, it did.
And so we really have to listen to the patient. And when she was listing off her medicines and exactly what was happening, I'm like, well, tell me about the Botox, and tell me about how you're taking this and what happens after you get it. And it was just by nature of coincidence, she started mentioning that her forehead moves.
But it brings up again the idea of listening to the patient, because obviously the person who was injecting her wasn't paying attention because she was twitching. So she was developing the antibodies, but they would have kept going. They would have kept injecting.
Yeah, no, and I think it brings up an important point of seeing the patient as a whole when they're coming in and understanding, not missing something, right? I mean, Chiari patients,
That's right.
Patients that have other type of underlying disorders, but also people that have an incidental finding on MRI and avoiding surgery and unnecessary surgery.
The aneurysm,
and
like you said.
The aneurysms, the Chiaris, the arachnoid cysts.
That's right.
Questionable hydrocephalus. It's really scary how many people get unnecessary brain surgery because, well, it must be the headaches, or you've got, again, back to the silo themes of a doctor saying, well, I'm reading the MRI report and they're saying you have a very significant Chiari, and, well, Chiaris cause headaches. Then you go to a surgeon who doesn't care about the headaches and is like, well, they're saying that it's from this, so we're going to book you next week. And then what happens? And you get the post-op who now, the headaches are usually either worse or certainly not better.
Yeah.
So it's really important to kind of have that holistic approach. And I don't know if there's a question that says feverfew. I don't know what that means.
So feverfew is also a holistic medication that has been shown to be helpful with headaches. I mean, if you look at the literature, there's actually a movement to start more holistically with headache treatment, because is it a migraine? Is it a cluster headache? Is it a tension headache? I think going from a holistic approach, you can almost hit all of the headache types, and feverfew is one of the options available there. I do want to say that you can't get too bogged down with the holistic medications because we do not have a lot of data for them. So you have to be wary. I mean, ginkgo always comes to mind. Ginkgo is great, but it has drug interactions. There's yeah, you know, there's red yeast rice. So many people take red yeast rice to lower their cholesterol, but it's actually a statin. It's a plant statin that we derived all of our other statin medications from. So if you're on other medications, you could have interactions. So really be careful when you start down that road of recommending holistic medications.
Yeah, and it's a really good point. There's so many. Was there another question?
Yeah, while we're there, the question came up with MAG and B2, the mechanism of action, and can it be used for other complaints such as back pain?
That's a great question. So not as much B2, but magnesium we know is great for muscle spasms in general. And as everyone knows, that one of the proposed mechanisms of action for headache is a muscle spasm. And the same thing for back pain. We have to know the etiology of a back pain. Doctors Stringer, Hakma, and Sarkar this morning discussed that there's many different kinds of back pain. So if it's a muscle issue in the back, absolutely you could use magnesium. We actually put our post-op spine patients on magnesium because what patients complain about post-operatively is the spasm. That's what hurts more. They fixed the actual back pain issue. It's now the muscles around that they've cut and they've had to move that are spasming, and that's what hurts more.
Right. Right.
And before we leave Dr. Liebman with trigeminal neuralgia, the question came up, the drug of choice to treat it, and what is the dosage and the length of treatment?
Well, usually the drug of choice is usually Tegretol, and but it's when we say that, it's important to identify typical versus atypical trigeminal neuralgia. The typical is the lancinating brief pain, much like an electrical shot in either the V1, more likely the V2, V3 distribution, and then you go more a Tegretol, an anticonvulsant route. I tend to be a little bit quicker on the gun with Neurontin, Gabapentin, Lyrica. My patients, I found that they have less of side effects than with the Tegretol, with the phosphenotoin. If they have atypical facial pain, there's thoughts to actually not necessarily an anticonvulsant route, but rather a tricyclic antidepressant route. So I don't know, Natalie, if you...
Absolutely, I tend to agree with you, and I think we both agree that we will go more the gabapentin and the Lyrica route over the Tegretol route because so many patients have side effects from the Tegretol. We have to monitor their LFTs. This is not something that's just benign, here you go, take it, and we'll see you later. They have lots of monitoring and side effects that we have to worry about. And I know with patients like this, they basically say, just give me something, and because they're in so much pain, but I'd rather give them something and not hurt another organ.
No, it's exactly right.
And the gabapentin and the Lyrica really do help in those situations.
That's right.
It's almost as if you know the next question. Have you ever used gabapentin for treatment of headache? And can you speak to that?
I think it depends on what the etiology of the headache is. We actually use a lot of gabapentin in the treatment of post-op headache because of the nerve component of the headache. So a lot of post-op Chiari headaches, Dr. Vez, you brought up, they come back and they say that their headaches are worse.
Yeah,
and
sometimes if they have neuropathic pain, so the point being is that some of our incisions, because they're close to nerves, the occipital nerve, they will get headaches or pain. So that's, as Natalie said, is exactly right. That's where we do use the gabapentin for like neuropathic headaches that are post-op.
And it really is important to understand what you're treating. And we call a lot of things headaches just because it fits into that bucket. So it's really important to focus, really to me, the pain. You know, where is the pain? What type of pain is it? And then, you know, we can treat it accordingly.
Yeah, I mean, I didn't want to bring like occipital neuralgia. I mean, you're right. That's often described as a tension headache because it's coming up, and so you're right. And then it gets back to that common theme of listen to your patient, examine the patient. Do they have a scar near the occipital nerve? I mean,
Or a trigger point.
Yeah, trigger point too. Exactly right.
I mean, we'll see patients and they'll come in, they'll say, well, my headaches are back here, and you start rubbing, it's out.
Yeah, it's exactly
And you
right.
literally can localize with one finger, and that treatment's real simple. We're taking out lidocaine, and doing a focal
injection.
steroid and long-acting numbing medication, and it works wonders.
Absolutely.
And it sure as heck beats being on, Tegretol or, some of these other medications for very long periods of time.
And just in terms of going back to injections, we have a lot of patients that we see that other physicians are nervous to inject because of scars, because of surgical procedures that they have, which then we get back to us, and then we end up doing the
That's right.
injections.
That
And
case we just did, there was a patient that had a Chiari decompression years and years and years ago, and literally has a large cranial defect in the back, and none of the headache doctors would touch her with Botox because they were worried. So Natalie and I did, and it was, because we're comfortable with it, we know what it is and where it is. As we're talking about medications, I don't know if you want to speak a little bit, because there's a lot of questions that we get, and I know you get even from the other doctors. You want to talk a little bit about the newer medications out there, the new category of anti-migrainous medications, the injectables?
so the newest category out there are the Cgrp inhibitors. So those medications, I think, have been a game changer for patients because they inhibit what is now hypothesized to be one of the main pathways of migraine headaches, which is the Cgrp molecule, and they inhibit that pathway. There's several medications out there. They're all injectable. There's actually 2 oral medications that were approved that are approved for not for prevention, but for treatment of migraine. But we don't have data yet to show whether or not they can be taken together. So can the patient be taking an oral medication along with an injectable?
Right.
Or if it really makes sense to double up, if we're already inhibiting Cgrp, do we need to inhibit it more? What the data I would love to see, and I think we all would be for headache, post-subarachnoid headaches, for post-ICH headaches, any kind of...
Well, you just came up with live on air our new study and trial that we'll do, and that's a great. But what you're seeing right now, this is how we are all the time. I mean, we're together, and we, all the doctors interacting, and this is how a lot of what we've done. 9-hour IV TPA, intraarterial chemotherapy for brain tumors, MMA embolizations, is sitting down, and everybody, I would have never known that. You know that data, you know that trial. We're like, well, we've got a lot of patients. There's no risk to it. Let's start collecting the data so we can work together and come up with answers. That's great. But I know a lot of the patients get very wary when they hear injectable.
Yes, I know, and the companies have actually been great. They've created auto injectors. So it's not how it was before, or people think insulin. I think insulin is our big trigger. Yeah, where you have to draw up. I mean, we have the pens as well, but old school insulin, you draw up the vial, you have to give yourself the dose, make sure everything goes in. The new technology, or for lack of a better term, is it's a pen that you just hold to the area that you're injecting, and you press a button, and it injects. And so there is no real formal training that's necessary for these medications. You don't need to reconstitute anything. You don't need to draw anything up. You don't need to make sure that it's the right dose or not. It's just auto injects, and you're good to go.
And it's safer.
It's safer because the needle then retracts.
Yeah, but you're also to the dosing, to your standpoint.
That's right.
It eliminates overdosing, underdosing to see that's, and again, it gets back to, I'll argue this with anybody until the cows come home, and you guys know that for anyone. We're not getting anywhere without industry. I mean, we're not getting anywhere in healthcare, in anything without industry. We've really got to partner. And it's great because we call industry out. So I mean, there's a front page article in the Inquirer not long ago showing all the conflict of interests of some hospital CEOs that are getting not thousands, millions of dollars from industry.
Interesting.
Like that's, I think, where we've gone wrong because,
Right.
and I'm not calling anybody out. Listen, God bless them, and whatever's legal is legal. But I think there becomes a very slippery slope of, we are hard on our industry partners, and for all of our industry partners out there, you can vouch and call in. I mean, we give them a hard time. We're like, look. This is what you need to do
Right.
for our patients. You need to listen to us. This is what you need to do, and we can do that because there's no money in the till. There's no, it's a one-way street. Our relationship with them is help us find cures and help our patients. You're going to do what you do. God bless you, but that relationship is really important. I don't mean to go off on a tangent, but I think it's just yet another illustration of how we can work together with industry, keeping it transparent and clean so that we can come up with these cures. So I think the next level now is what do we do with the patient that comes in that's had first line magnesium, the holistic approach, they're sleeping great, they're changed their diet, they've been on an anti-epileptic, they've been on, now they've failed the injectables, and we know it. I mean, for those of you that suffer headaches and for those of you who treat patients with them, patients literally get suicidal. I mean, imagine every day or every other day having a debilitating migraine that you have children, you have work, you have life to deal with, and you just can't. And everything else has failed. So, those are the patients, I think, that are, and we're going to talk about some of the things that are next level, and nobody has the answers to.
Nope.
And I think some of these patients have been, they become victims, just like the patients with failed back syndrome that are in chronic pain and they can't get answers. That's where you get into the hands of people that are going to take advantage of that. And, well, here, I'm going to sell you this pill, or I'm going to give you this, patented infusion. So I think those are the patients we really got to put science to. We really have to think through it carefully, try to figure out different methods that are safe but escalating so that we can see what works and what doesn't. So I think the first line in that is not ever first line should be, but unfortunately some places it is infusions.
Absolutely.
And there's some really great, it's people will tell you to save their lives. So I don't know if you want to talk a little bit about, we're about to get our infusion center going so that we can start looking at this, but we need to find the right, first and foremost, the right patients, right?
Right.
We talked about coming up, making sure that they're really failed everything else, that every stone has been unturned. But I don't know, Natalie, if you want to talk a little bit about the different infusions out there and kind of from a stepwise.
So we mentioned briefly magnesium, and really, if somebody is in status migrainosus, I think that's the first thing that we're going to try is we're going to say, you know what, like at this point, we need to break your headache, or we need to break whatever is happening. So let's send you to an infusion suite. Let's get you some magnesium. Let's get you some Benadryl. Let's get you a steroid, and see if that helps. If they're nauseous, put on some Zofran with that, and see if an IV infusion with a obvious better absorption will help them with the treatment option. At that point, if that doesn't work, we can escalate our therapies. We can go and do a valproic acid infusion, another great tool that we have that not only for headache treatment, but for a neuropathic treatment. So trigeminal neuralgia patients, we oftentimes will send to infusion centers to get loaded with a valproic acid to help control their pain. And we're doing two things we're number one, controlling their pain, but number two, we're preventing an ER admission. Right. And I think we miss that at times, that yes, from an outpatient office perspective, these patients are calling and we're constantly in conversation with these patients, but what's the alternative?
Right.
It's admitting them and really treating them as an inpatient, which we do sometimes, but it's not something that we want to do first line. It's not something, we want to prevent admissions as much as possible, and we want to utilize all of the tools that we can from an outpatient setting.
Yeah, and I think it's really shocking to see how many patients use the ER as their headache clinic.
Absolutely.
Where they're known and they're getting ganglion blocks, which we can talk a little bit about. There's some other things, propofol infusions. And in today's day and age with COVID, I mean, the last thing you want to be doing is getting admitted to a hospital for headaches. in COVID.
The problem with these patients is not only do people not know what to do, doctors don't really want to deal with them. They
That's
just
right.
keep kicking them
That's
off,
right.
and they don't know where to go. I mean, so they wait 6 months to go to a headache clinic downtown that really isn't doing anything novel. So they, as you said, they go to the ER, and their ER doctor is their headache doctor.
That's right.
And you know, we speak with our ER command center all the time, and they say, "Oh, we've got another headache patient." Well, great. I mean, you know, treat the either you can discharge them and they'll go straight to an infusion center, or you know, treat them in the infusion, but don't admit them, because unfortunately, there's nothing we could do from an inpatient standpoint that we can't do from an outpatient standpoint. We want to keep these patients out of the hospital in the age of COVID, in the age of just the amount of healthcare dollars it's going to take to treat these patients. We want to be mindful and treat them appropriately, and we can do that without having to do an admission.
That's right.
Yeah, no, really, really important.
For the emergency medicine physician, if a patient does present, what is the approach you would recommend in a stepwise fashion?
Great
and a question, sort of follow up to that, what about intranasal lidocaine for acute migraine?
So the approach that we, I think, all take is the first steps are the magnesium infusion along with an anti-nausea medication. So whether that's Compazine or Zofran, and then a Benadryl, and hydration. We oftentimes forget about hydration. So what I like to almost equate this to is when you're hungover. And all these infusion centers, no, of course.
I'm hungover right now.
They make a lot of money on Myers cocktails, and that's a banana bag.
Yep,
You get a banana bag, and you feel better. You get your vitamins, and you get a liter of saline, and so that's what makes you feel better. And a lot of times, you know, when these patients, they're nauseous, they're throwing up, they're not eating, that could be another, it's almost escalating the reason for their headache. So that's step one that we like to do for our headache treatment. Then we'll go into potentially giving a triptan, giving an infusion of valproic acid, giving other modalities if possible. But really, we start with the low-hanging fruit, because most of the time, if you don't overthink it, it'll do the trick.
Yeah, but once that you get past that, and the headaches, lidocaine does work. The ganglion blocks work in some people, but it's a temporary measure. And
that's correct.
You know, we've seen a trend of patients literally coming to the emergency room to get those treatments, and unfortunately, there's a couple pop-ups, more than a couple now, pop-ups out there where you can get that banana bag for a couple $1,000s.
That's right.
Cash, by the way. You know, that's, you know, it goes down a different path. But I do think it's effective. I've seen it work in acute situations.
And a question about imaging and where that fits into the workup. And if somebody from out of state is concerned they had a CT, MRI, want us to look at, is there any intracranial pathology that may be explaining headache? Do we have a way of looking at that and providing feedback?
Yes, so the first line, and it's actually a great question, the caveat, even before we start with magnesium, nobody is going to start getting treated anyway that anybody that GNI sees without imaging, because, you know, lots of things that are you know, more serious can be causing the headaches. Even in patients that have known migraines. I mean, how many times have we seen ruptured aneurysms that they have a sentinel headache and they've had migraines their whole life? They're like, whoa, I knew this was not my normal headache.
That's right.
They need imaging, and it really I mean, MRI is the best modality. I mean, CAT scan's a great screening tool. I love MRI because there's no radiation. You really don't need contrast. And yeah, it's a little bit more of an expensive study, but it's gonna tell you if you have a Chiari, a brain tumor, any type of space occupying lesion, hydrocephalus, arachnoid cyst, hypotension, intracranial hypotension. I mean, it really answers a lot of questions. So the first caveat is that your imaging is normal and there's nothing else that's being missed. You're not being treated for headaches and you have a brain tumor. And secondly, yes, GNI has a, which today we were screening our calls from this morning, GNI has a great second opinion website where you can download films if you're from out of state or out of the country, and we can look at them and you know, and it's free, and you know, help with some guidance.
But there's an important point to imaging, and that is there are, again, it gets back to listening to the patient. I mean, in terms of there are certain things we're going to listen for that increase the risk or heighten our concern that it's a secondary headache, that there's intracranial pathology. And then it gets back to also that not every intracranial pathology is causing the headache.
Right.
So it's really important to have the person who's looking at the films to really understand what's going on.
Yeah. And what about Moyamoya? I mean, patients that have, young patients, usually their arteries slowly shuts down, and the vessels in the brain that are feeding the brain look like a puff of smoke on angiogram, which is Moyamoya is Japanese for puff of smoke. A lot of those patients have headaches, but I'd really like to try to manage them with medication rather than do a bypass surgery on them.
Absolutely.
There's lots of factors in there, and so it's an important thing. But once we get past all of that, so the infusions aren't working. So now we're trying ketamine. We're trying, really outside the box with the infusions. Now what's left? So now we're talking about that kind of minority bunch of headache patients. And so what we started, I think we have a slide that we can put up. And this goes back again to thinking outside the box, taking all the tools that we have, and being able to start thinking about the disease. So we're infusing, and this came from our chemotherapy, giving chemotherapy in an IV versus dousing the brain tumor with the chemotherapy.
Right.
We know that pain, so many people don't realize, a lot of doctors don't realize, we do awake brain surgery. And I think the thing that freaks people out about that, well, first of all, being awake for any surgery, but brain surgery is that, oh my God, it's painful. The brain has no nerve endings. We operate on the brain while the patient's awake, and we can poke on the brain with something sharp, and they're not going to feel it unless you go too deep and take out a motor pathway. But there's no nerve endings. There's no sensory nerve endings. But where the nerve endings are on the dura, the covering of the brain. That's where I believe headaches come from. That's where the vascular spasm comes from that causes that. And so the picture that you're seeing on your screen is the picture that we showed you from that young child where we're shutting these arteries down for the subdural hematomas. That's an external carotid artery injection, and those blood vessels that you're seeing are going to the covering of the brain. They're going directly to the dura. So why don't we try some of these, even if it's magnesium, injecting with a microcatheter and covering that dura. And this is an extremely safe procedure. It's like getting an IV in your groin as opposed to in your arm, because we're going into an external branch, and of course there's risks to anything, but so we just started looking at this and doing this. We're highly selecting patients. We have 2 patients, one who literally attempted suicide because of her headaches. The problem was she has bilateral headaches. And so that was a warning sign. What we're looking for is somebody with unilateral focal on one side so that we can basically eliminate and take that, that component of what might be the etiology out. So it's something, again, that we can talk all we want about, well, it doesn't make sense because of this, and there was a paper written on that, and this medication, okay, well, we don't know that. Why are we using anti-epileptics for headaches, right? I mean, why are we using, a Neurontin for chronic pain? Because we don't really understand, it's not we don't understand the drug, we don't understand the etiology of the symptoms of these diseases.
No, a lot of the treatments are not intuitive. You're exactly right. And patients question, they wonder, why am I taking an anticonvulsant for my headaches or my neuropathic pain? It's exactly right.
Yes.
Well, I oftentimes, especially with the tricyclic antidepressants, I often say, I'm going to put you on this medication, and it's not because I think you're depressed.
Right, that's right.
And I have to explain that because we've gotten calls before like, I'm not depressed, like, or I don't have this.
Head.
Yeah, or you think it's in my head, you think I'm crazy, anything. And you really have to have that conversation, say, this is not why I'm putting you on this medication. Or same thing with anti-epileptics. I don't think you're having seizures.
Right.
Trust me,
Right.
it's for other reasons.
Yeah, no, it's true, because there's a stigma of taking an antidepressant. There's a stigma with taking an anti-epileptic.
Right.
And I think it's not benign.
And then those who say, well, I'm not drug seeking, the ERs keep thinking I'm drug seeking. So it's,
right. And I'll tell you the one really great thing that I think, the change with the opioid crisis is, we're seeing fewer and fewer headache patients being treated with narcotics because that was a problem. And the rebound headaches that these patients would get, because they get, no one's going to give, most people aren't giving an unlimited script of say Percocet, but they're getting a narcotic for 1 week or 2 weeks, and my headaches are gone, then the narcotics stop, and now you got a rebound headache, not to mention the addiction risk. But I think we have a question.
Yeah, another good question from an EM colleague. She was sharing that Reglan, IV fluid, plus or minus Toradol, plus or minus Benadryl is a current approach, and was just asking if you're suggesting MAG 2 grams and Zofran instead of or after that typical cocktail, if you will, has failed. So just clarifying where they all fit together.
So I think you have this bag of medications that you can choose from. Reglan is a great medication to choose from that bag. Obviously, if you're going to use Reglan, I wouldn't use Zofran. Same thing with Toradol. Toradol is tricky. It's great if you've ruled out any other type of pathology or etiology. Also, it's not oftentimes that we can give Toradol for patients that have had a post-operative type of situation where we really want to avoid any kind of NSAIDs. So I think it really depends on what your patient is presenting with. I think the medications mentioned are a great first approach. If that doesn't work, you can go to magnesium. If it does work, or you could go magnesium first and then something else later, or you could do all of them. Most of the time in an emergency setting, the patient's probably getting all of the infusions, or it's not even infusions, but they're pushes, sequentially. So it's just seeing what the patient is responding to.
It's a great question.
It is a great question. What about the patient who says, I've been reading all about CBD, about medical marijuana. What do we say to them?
That's a great question, and I think that there has to be more to come on that. Yeah. I think, unfortunately, there's so many different kinds of strains and THC to ratios, and so I think they're great to try, and we have some prescribers of the medical marijuana route, but I think it also it's so patient specific, and it's so specific on the strain that the patient has, on the clinic that they go to, on the route that they're getting this administered. Is it a tincture? Is it a capsule? Is it something that goes under the tongue? Is it something that goes into a brownie? I mean, all of that does play a role in how the patient responds to the treatment.
Yeah, and we're actually, to that point, we're doing a national trial right now with our colleagues around the country for Chiari with that, because a lot of the Chiari patients take medical marijuana and CBD. The problem is, as Natalie said, it's all over the place. There's different strains. People are smoking pot at home from their own stash, and so you really have to bring it down to, we're going to try one strain, see which strain works, what dose works for different people. So it's really, and I didn't realize that either until we started really getting into the medical marijuana and understanding it, that it is so varied. I mean, you go into a store, it's like Purple Haze versus Sunday Surprise. Well, what the hell is that? I mean,
but like you said, how you smoking, edible, under the tongue. I mean, there's so many different ways also that you're delivering it,
and how it's metabolized, and how each individual is metabolizing it.
And now it's not just CBD; it's the THC component as well. So it's the ratio of one to the other, and so it's really it's tough right now to figure out. You can't just blanket say it's going to work for everyone. But we have had patients that have said, I've gotten my medical marijuana card, I go, and it's worked out great. But other patients have said, I've tried different combinations and it's done nothing.
Right. Yeah.
Just like with every treatment.
I was just going to say, like every treatment. Now there really isn't any secondary gain here, because people want to smoke pot today. It doesn't matter what state you live in. Whereas before, I think when it first came out, I was like, ooh, wow, I can get a prescription for pot. But it's not that anymore. And we've seen, and I know you've seen in all of our clinics, people swear by it. I don't even care if it's placebo effect, as long as there's no negative adverse effect. I have little old ladies who are coming in that, I want to make a point, just getting back to the imaging as well, because this is especially for all of our emergency medicine colleagues, nurses, techs, docs. the headache in the ER, and you know, Ken and I and our vascular colleagues live this. Somebody's coming in with a bad headache. I do not care how bad their headaches have been in the past, what their history of migraines is. You have somebody with a thunderclap headache, that patient has to be ruled out for subarachnoid hemorrhage. And
I agree.
every year at some of the best ERs around, you see that patient that, oh, it's Steve again, and he's coming in. And 10% of the time, a CAT scan will be completely negative, a plain CAT scan. If that story and history is good enough for a thunderclap headache, worst headache of your life, you have to rule that out. And whether it's an MR, LP, you have to rule that out because that is a fatal mistake.
It's a great point because I'll often ask the question, because they'll say, why image? I'll often ask the question, well, why'd they come into the ER? Because they had the worst headache of their life. Well, then that warrants, and I can't agree more, that warrants imaging. And if the story is so suspicious, a plain CAT scan, we need to go further. We need to go further in terms of either LP, MRI, or vascular studies. But I think that's a really good point.
Especially it's easy to get now. And, you know, not to, you know, I don't want to go on how many years you and I have been doing this, but think about even going back to a resident. I've never seen somebody come in with a ruptured aneurysm that was like, you know, very subtle and just a sentinel bleed, where it was gradual and it came on, I went to bed, it's still there. That's not the headache we're talking about. And I've yet to see, I mean, every subarachnoid ever, it's always that, almost always. And now they may have had that a couple days ago and they forget it, but it's still that sentinel headache. That's right. There's a question.
Another question from an EM colleague about the headache clinic, and is there somebody on call at night on a weekend should there be a question about a patient who presents with headache?
Yes, absolutely. I mean, we are available, not just neurology, neurosurgery are available 24 hours a day, 7 days a week, and it's a direct cell phone number. When you call that GNI number, again, this isn't for patients, this is for you, the healthcare providers. You're getting, you know, right now, you'll be getting Zach Hockman. Actually, he's in the operating room with an aneurysm, so he'll probably be getting Stan. You know, tomorrow morning at 7 a.m., you'll be getting me. On neurology, you'll be getting, you know, Dr. Sirkin, you'll be getting, all that comes in directly to us. If somebody's having an acute enough exacerbation, we're going to bring them in. And we're not just going to say, go to the ER, and then you're stuck with, well, my doctor told me to come in because I'm having a bad headache. We're going to work with you. You're going to, you, the provider, will call us, and we'll say, oh, yeah, they called the office, we're doing this. If it's in our neurologic emergency room, our first phone call is to Dr. Greenberg and her colleagues saying, listen, we got a 34-year-old coming in who's having a very different variant of headaches. They know what to do, right? They're going to understand that, get the CAT scan. They're going to know if it's severe enough to do an LP or a CTA. So the answer is yes, absolutely. And it's a great question because you can't, headache doesn't occur just 9 to 5 in clinic hours and here's an appointment. And just, yeah, so we have up here, the number is our outpatient on-call number is 215-938-4765, and we'll get all this for you. Nicole Myers, who's on the WOVA app platform, will get all these numbers for you. So these are cell phone numbers that go directly to the doc, whether it's inpatient, outpatient, and certainly emergency. Okay, there's another question here that I think Tom's too shy to ask, and he's writing it. Orgasmic headache from thunderclap. So no one ever wants to talk about that. So first of all, God bless you, you're having a great sex life if you're having an orgasmic headache, and I commend you. But it's a real entity, and people are afraid and ashamed and feel inhibited to talk about it. But it is a real entity, and it is something that it's actually debilitating because, I mean, taking the joke out of it and the humor, I mean, you know, imagine every time a man or female that you're having an orgasm, you have this headache that is the equivalent of a ruptured aneurysm. So it is real, but it has to, like everything, it has to be ruled out. So if you're having that type of a bad headache, if it's a ruptured aneurysm, it's usually not going to get better over time, over minutes to, really I would say it should be within an hour, should completely relieve. But if you're getting that, you need a full evaluation. And
actually, not getting into details, but I did have a patient, and they were a little embarrassed, but they finally teasing it out. It happened every time they had an orgasm, but that's exactly, I didn't say, oh, this is what it is. I got the appropriate imaging. I got the appropriate workup. Then it was a diagnosis of exclusion. But that's exactly right.
Yeah, we see it all the time. And you also see it it's not uncommon that you see somebody who does rupture an aneurysm while having sex.
Absolutely.
I mean, that happens. We see it all the time. And just to kind of close our session, I mean, one of the most bizarre situations I was ever in is back when we were at Jefferson, and this young gentleman came in and was, having sex with his partner and had the worst headache of his life, but it didn't get better and it went downhill. We had to take him to the operating room and treat his aneurysm, and I'm in the conference room talking to his wife who was with him, and then after we're done, his real wife shows up, and I'm like, whoa, and that was so it happens, folks. So that's the end of our session, and what we're going to do is we're going to stay on and answer questions from, do the panel discussion. You'll also have the 3:30 one, but we thought just from, so there's not this kind of stop and start, we're going to stay on for the next half hour, answer any questions, and you can do the whole day, any questions from the day from a panelist standpoint. But we'll also, if somebody's clicking onto the 3:30, we'll all be here. So I think we do have a bunch of questions.
Question to round out headache, and it related to the latest generation of CTs for identifying acute subarachnoid hemorrhage, or MR. Your thoughts?
I know, Ken, if you want to chime in too, it's not really the latest generation. I mean, CAT scans, if you have a 16-slice CAT scan in your emergency room, that's going to pick up a subarachnoid hemorrhage. I think the 265, the slices are just more accurate and they're better at identifying the blood vessels. A basic CAT scan is going to pick up a subarachnoid hemorrhage.
If the patient presents within the acute period, so the patient presents within the first 48 hours, which they usually do, then a CAT scan will pick up 98 to 99%. I mean, that's how sensitive it is. And as Erol said, in terms of the latest generations, the cut versus the slices, the thinness of the slices, obviously you'll get more sample size, but the vast majority, 98 to 99% of the time, you will see it in the acute period.
Now, that being said, the really small amount of blood or a hemorrhage that occurred a day or so before, MR is going to be much more sensitive for that. MR is, pretty much the equivalent of a lumbar puncture. And a lot of times people are doing lumbar punctures because they can't get an MR in the middle of the night.
Right. The gradient echo sequence on the MRI will show blood that's happened when they were a child. My point is that's exactly right. It will pick up a subarachnoid hemorrhage no matter how small and what age.
Any difference if within the first 6 hours, even more likely to pick up on CT? There was a question about, does the literature support CT to rule out if done within the first 6 hours of presenting to the ED?
We usually start off with a CAT scan, non-contrast head CT, although there is radiation, but the radiation is not significant and it's extremely sensitive to pick up a subarachnoid hemorrhage.
The earlier, the more sensitive. After 6 hours, 12 hours, if it's a small, small bleed, it will be less likely to be picked up, and that's where MR is really important. So any questions, please, from the entire day or even from yesterday? We have our panel here, and one of the things that we're doing actually, which is really, we're really excited about, at 5 p.m. today, I think we have up to 150 patients. We're doing a session called Ask the Doc. So we took an ad out in the Metro. All of our patients got emails. We actually advertised it a few weeks ago, and we weren't sure what kind of outcome we would get, and there's 150 patients signed up so that they can just ask a panel of doctors. Everything from I have a tremor in my hand to headaches to back pain to medication issues, pharmacologic issues. So we're really excited about that. It's going to be interesting. It's either going to be a complete chaos or it's going to be, and we've done this in person before for those of you that have been to our conferences in the past. We've done that, and it is so amazing. And it just strikes me how hungry some patients are for just access to talking to doctors. And we live in Philadelphia. We live in central New Jersey. I mean, where you can throw a stick and hit a medical center. It really is incredible. And to me, it shows the breakdown in the healthcare system of access, particularly for neurosciences. So, and actually, to that point, we've gotten some great questions. A lot of urgent care folks out there. Nurses, docs, who it's really great to see them because, you know, you guys and gals are on the front line too of people just literally, you know, it's just kind of like an ER. It is an ER, I guess, and seeing a lot of this stuff. So that's the same thing. Anybody out there from an urgent care center, those phone numbers we're available 24 hours, 7 days a week, and we're agnostic, meaning if your urgent care center, you have a relationship with it doesn't matter what the hospital or facility is, you can call us, we'll walk through the patient with you and, help you with triage.
What's really unique is you're not going to get an advanced practitioner, you're not going to get a nurse, you're not going to get an answer.
You're not going to get a transfer center of somebody saying, hold on, I'll do this, and these awkward 3 people on the phone. I mean, you know, that was another common sense thing that listen, we pay the price for it, but it takes all that out. I mean, healthcare providers should talk directly to a healthcare provider about a patient. And we don't have, you know, any ego either. I mean, how many times a night do you get a call or a day from a resident, from from anybody? I've had calls with before.
So have I, absolutely.
Which is fine, to a point. I know a little something about the patient. So yeah, we don't want to confuse people either with the 3:30. We really want to get to everybody's questions.
Question about, back to headache for a moment. Is there a standardized assessment tool that can be used in the outpatient setting during the initial workup? And then Natalie, you mentioned the follow-up calls by the APPs. Is there some standardized approach to assessing the patient over time?
Absolutely. So I think if you Google just standardized headache approach, you're going to get a ton of different handouts out there, and they all basically say the same thing. This is the type of headache I'm feeling. Is it burning? Is it itching?
Throbbing.
Is it stabbing, throbbing? And they all ask the same questions because we just want to get that information out of the patient. And then what kind of medications have I tried? You know, it's a process of elimination. If you've tried something and it hasn't worked, you know, we take that off of the list. And that's how we do the follow-up questionnaires as well. We basically say, has this worked? Has your headache gotten better? Has it gotten worse? Did something happen in between? Side effects, anything. And that's how we can assess for next steps in therapy.
Yeah.
A question for 2 vascular neurosurgeons and a neuropharmacist related to spine. So post-op spine, what are the limitations? What would you recommend to a patient as far as getting back to normal activity? How long
surgery?
after spine surgery?
So it really depends on the surgery. I mean, it depends on what you've had done. Have you had a fusion? Was it an unstable, certain people their spines, especially up in the higher cervical, are very unstable. So even after we put screws and plates and all that hardware in, it takes time. Really, what is all that metal's doing, which people don't realize, is all it's doing is holding the bone steady so that the bone itself can fuse. So it's stopping motion. So whether you've had that or you've had a simple discectomy, it really determines on what type of surgery you've had. And again, it's a really important question because some docs just do this blanket, well, you can't drive for 6 months and you can't do this. You've got to individualize. And you also have to individualize to the patient. Somebody could lose their job if you're trying to hold them out of work too much. So again, it really makes a big difference. Now, I will tell you what we've done, and again, with the help of Natalie, is we're using a medication called Erol. And it has been a game changer. So this is an injection after we do surgery, and we're using it cranially now as well. We inject this muscle. It's a very long-acting, it's like a lidocaine. It's a numbing medicine, but it lasts for 3 days. And we inject it directly into the muscle before we close our incisions. And I mean, it's a game changer. These patients they can get back to, immediately, because I think the biggest limitation is pain after. But, and I don't know if you have any other concept of when to get back to.
In terms of, it depends, in terms of like a microdiscectomy where it's a minimally invasive procedure, you want to prevent or reduce the risk of re-rupturing or re-herniating the disc. So you limit the activity in terms of, but I don't ever do absolute bed rest. I try to limit sitting because I think Natalie brought up in terms of muscle spasm. So it's a greater chance of muscle spasm with sitting. I prefer standing or lying down. If we do a fusion, depending on if we do a fusion from the front and back, whether or not they're going to wear a brace, and they wear a brace if they're sitting, standing, or walking, and then the length of time, but not all the time. Now, lately, we've done with, historically, with anterior cervical procedures, we used to wear collars, but now, if we plate them, which we do almost 100% of the time, they go away without any collar, and there's not a lot of limit in terms of their activity, other than no heavy lifting, but they can get up, they can walk around, etc.
We're very, very aggressive with getting patients back to, I mean, we did, as an analogy, if you have a ruptured aneurysm, and let's say you come in, it's just a bad headache, and you're fine other than the headache, we realize it's a ruptured aneurysm, we treat your aneurysm, up until, and a lot of places still do it, you are bed rest for 21 days. So imagine, you're in the hospital in an ICU for 21 days and you can't get out of bed. That's just stupid. That's from before we were even in medical school, and no one ever changed it. And so remember the study that we did with our physical therapy colleagues, we wrote the paper on it, that early mobilization, IVTPA. So think about this. Let's go back to common sense. And I didn't do this in my slide set because I wanted to kind of just focus at 30,000 feet. But Mandy Binning and the team where we come together for our research meetings, you get IVTPA, you have to stay in bed for 24 hours. Sure. You can't get IVs. You can't get it's crazy. And so it's based on, the half-life of IVTPA, which people don't realize. So 24 hours you can't move because of the IVTPA, and the half-life is minutes. So it's out of your system. It's really the fibrinogen. So we're checking the fibrinogen levels. And if you have the ability to clot, we're getting you up out of bed and moving. So it's the same thing with the spine. It really, we want to get people up, moving, back to work, back to normal activity as soon as possible, but without having them hurt themselves.
And of course, we just want to remember that we fixed one problem, we don't want to cause another problem. And with stasis,
DVT,
exactly, that's what we're
Pneumonia,
causing.
infection, depression, muscle pain. Yeah. Here's
another question about migraine. Is DBS ever an option? Any indication for DBS in migraine?
That's a great question.
That is a great question.
And what I would say that they're looking at is not DBS, but they're looking at stimulation. So it's more of a superficial, and again, getting back to that dura and the source. So there are answers for it. My personal opinion, and it would be interesting to get at them, I think it's kind of aggressive, but again, people that have failed every other option, there are stimulators specifically for headaches, and we've actually kind of talked about this, but we're gonna try this chemical approach from an arterial approach first.
That is an interesting question, because there's also thalamic pain syndrome. So is there any way to deliver some type of agent to the thalamus, intraarterially? So it's a good point.
Functional neurosurgery is
Oh, God.
I probably would have gone into functional neurosurgery if it was back then. Now we're looking at surgery for opioid addiction, OCD.
Oh, absolutely. Right.
Dr. Bob Sadaloff, who's a really well-known and actually world-famous vocal, he's an ENT vocal specialist in Philadelphia. Him and Dr. Sarkar started the world's first vocal tremor center for DBS, because we know the area where vocal tremor is, and it's just incredible what we can do. But I don't think we're quite there yet.
Okay, someone's saving you from spine and functional. So back to vascular. When the TCD and clinical status indicates vasospasm, what determines going to intervention versus IA nicardipine?
Great question.
We first start with the medical management first, because when we do any type of intraarterial, there are some risks. So what we'll do is, as I mentioned earlier, we actually did a study. The bottom line is, I don't want to go into too much history, but we like to reverse the problem rapidly. So the bottom line is, if a patient doesn't respond within 1 hour of medical management, we are bringing the patient to our angio suite. And depending on where the spasm is, meaning is it a larger vessel, we'll often go mechanical, doing balloon angioplasty, it's more durable. If it's a much more distal spasm, then we'll do a chemical vasodilator. It's not as durable, but it's in the more distal friable vessels, it's a little safer. So within 1 hour.
Time is key with that, though, because
It's like a stroke.
Yeah, it is a stroke. The vessels are clamping down, and generally the blood pressure elevation does the trick. But to your point, we're blowing a balloon up in a very small, several millimeter artery in the brain, and you can rupture that vessel if you don't know what you're doing.
That's right.
But it's a life-saving
Yep.
treatment.
Certainly brain saving.
Yeah. I think we answered. There was a question earlier on acoustic neuroma, which I think we got to. Just a different option. I know you were. We'll hang out for a minute or so just to make sure that we get everybody's questions. Again, we have the tomorrow session, so we can always put up the questions, and you can do it on this platform, the WOVA platform, and we'll get to it just like we did some of the other ones that lag behind. But I think this was a great session. Tomorrow we're really going to be focusing on some more neurologic aspects. We're going to be talking about memory loss and beyond Alzheimer's disease. That really is going to be run by Dr. Peter Glebus, Dr. Lester, and Dr. Gallo, who's our neurocognitive team. So that's always an incredible session and something that is beyond timely. With what's going on right now in healthcare with cognition. I'm sure there's going to be questions about COVID and the brain's effects, COVID's effects on brain. Sorry to interrupt, but that's actually a really good point. I was expecting more COVID questions in relation to stroke, and I don't know. They came up. The discussion. And then for those of you who have seen, they do kind of almost a pod. Dr. Sarker and Jill Farmer. Incredible dynamic. Those two have such great chemistry, but they're going to be talking about movement disorder, Parkinson's disease. You're going to see some incredible stuff of some actually DBS surgeries. Every time I see that video of this gentleman that couldn't hold a glass of water and in the operating room just go to this, it's just incredible. And then pediatric neurosurgery, which is, GNI's, it's our partner, St. Christopher's Hospital for Children at Drexel. We have a full pediatric program, so we're really going to go over the spectrum there. Dr. Lovin, and again, Dr. Sarker, who's doing epilepsy surgery for pediatric population. It's going to be great. So stay tuned, stay in, stay safe. Focused and stay safe, exactly. So, all right, and tomorrow I won't burp in the morning, I promise. So great, have a great break.